Hello everyone, and welcome to today's live broadcast, Rapid Whole Genome Sequencing in the NICU and PICU at Rady Children's Hospital, presented by Shimul Chowdhury, the Clinical Laboratory Director at Rady Children's Institute for Genomic Medicine. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by RCIGM Molecular Diagnostics. For more information about our sponsor, please visit their website at www.qiagm.com. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located at the lower left of your presentation window and type your questions into the box that appear on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in a slide window. To enlarge that window, just click on the screen icon located at the lower right. If you have any trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know that you're having problems. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left-hand corner and follow the process to obtain your credits. Please join me now in welcoming Dr. Shimul Chowdhury. I will now turn the presentation over to him. Welcome, sir.
Thank you very much for that nice introduction, and I'm honored to be here to speak in this platform about some of the work that we've been performing at Rady Children's Hospital. As I said, my name is Shimul Chowdhury. I'm a laboratory director at the Rady Children's Institute for Genomic Medicine. So a little bit about the Genomics Institute and what our mission is. I have a slide here to try and capture what we're trying to do. And so our mission statement states that we're trying to prevent, diagnose, treat and cure childhood diseases through genomic and systems medicine research. You know, that's kind of a mouthful in terms of a mission statement and when you talk about what we're trying to do to the population. So we tried to simplify it a little bit. So what is our vision? To save 6,000 children's quality-adjusted life years through rapid genome sequencing by 2020. So we speak often in our world about qualities, these quality-adjusted life years, adding quality years to these children's lives by using genome sequencing. And that our very, basic message and our motto is going big for the little ones. And what we mean by that is performing genome sequencing rapidly for the tiniest of humans out there, as we've seen in our short time up at the Institute, providing a huge impact for these patients. And so how have we got here to this point, being able to think about and providing genome sequencing within a couple days? Well, it wasn't that long ago that we performed the Human Genome Project, which took over 13 years and cost over $3 billion. Then with some of the new next generation sequencing or massive parallel sequencing technologies, now sequencing a genome was possible within a day and a half and for the price of thousands of dollars. And I think for all of us in the laboratory world, we envision and picture a time where we'll be able to sequence genomes in a day for hundreds of dollars, really making that price feasible to reimburse this testing for children all over the country. And so sequencing technology companies such as Illumina are really driving this forward and being able to make sequencing cheaper and more robust. So who are we and what are the patients that we serve? This is a picture of our acute care pavilion at Rady Children's Hospital that houses our NICU located in San Diego, California. And so here you see a quote from Ernest Rady, who provided a generous gift of $120 million for us to be able to implement his dream of providing genomic medicine in the NICU at Rady and throughout the country. And so I think this quote really serves this mission well. Children are an underserved community as far as research goes. They're a smaller market segment. They're overlooked. And we really see this as well, in that there are many children that need genomic testing, need rapid genomic testing, and they're not able to get this. And so our mission at the Genomics Institute is to make this a reality and show other institutions, other children's hospitals that this is possible. So as we looked at our landscape at Rady and our patient population, there are multiple components, multiple types of genetic diseases out there with different impacts and differing costs. So as you can see in this scale, for 10% of the kids within our hospital system, they actually incur 70% of the total cost. And these are generally kids with the rare and undiagnosed diseases. These are the kids that we've seen you can provide the highest bang for your buck in terms of quality-adjusted life years. As you go down to the other triangles, you see that there are more children within some of these other buckets. Healthy children, 76%, these are the kids that are coming into the hospital and then getting better and then getting discharged. And high-risk children, comprising of 14%. But again, you see that significant cost burden within these 10% of children that potentially could have severe genetic disease. And so we wanted to focus on these children with rare and undiagnosed disease, seeing that has the biggest impact in our costs for our public health systems and the highest potential for providing more quality-adjusted life years for these children. And so a stat that I always get startled by whenever I see the slide, even though I've presented multiple times, 14% of U.S. newborns are admitted to a NICU. And so some of those children will be there for a few days and they'll be released. But there are also many other children in NICUs that have severe genetic disease and are not able to get the testing that is needed. And so here's a picture of our CEO and president, Dr. Stephen Kingsmore, who came from Children's Mercy in Kansas City and really wanted to implement some of the groundbreaking work that he performed in performing rapid sequencing in intensive care unit population. So the solution to the problem. So the leading cause of death in the NICU and PICU is genetic disease. Conventional testing is too slow to guide NICU and PICU care. So sending out a panel test for a series of genes for your condition of interest, average turnaround time in the market is right around 4 to 6 weeks. Within the scope of acute, critically ill children in the NICU, this is too slow. At the same time, the majority of these genetic conditions are simple genetic conditions, so single gene disorders that we can interpret right now in 2017 with the right tools and right infrastructure. So for this burden that we have, and depending on where you look at the numbers, it can be between 5,000 to 8,000 genetic diseases in the NICU and PICU. We really feel that rapid genome sequencing has a potential to be a great first-line test to help our physicians, help our nurses on the front line taking care of these patients by giving them the ability to use rapid whole genome sequencing. And so here's kind of a snapshot of some of the work that Dr. Kingsmore had performed previously in his work in providing the Guinness Book of World Records from 26 hours from sample in the door to call out a provisional report for a patient. And this was actually described as one of the top breakthroughs in 2012 by Time Magazine. And so, again, applying this rapid whole genome sequencing for intensive care unit population is a novel concept, but we've seen in multiple institutions that Dr. Kingsmore has led, Rady in Kansas City, that this approach really works. And so here's a snapshot of our experience at Rady Children's Hospital over a 6-month period when we started our clinical research protocol. And so we had referred 116 families, 58 enrolled, and we were able to enroll 95% of the families approached. And so that really speaks to the trust that we have within our nurses and our NICU docs in enrolling into this study and, in turn, allowing those families to trust in the information that we're providing as part of the research protocol. We also enroll 2 external patients as well in critically ill children. And so 48 families are tested at the end of this data point, and we're able to provide a diagnosis for 48% of those children, so 23 diagnoses. Our fastest diagnosis to date was 43 hours, and 16 infants received changes in care. And so that could be a variety of things that I'll talk about in the next slide. But basically what this snapshot has shown us is that rapid whole genome sequencing not only can help to provide a rapid diagnosis in these kids, but can have downstream impacts in changing the care in these individuals. So here's some of our early results from the sequencing studies. So for the percent of infants tested, comparing what they'd seen in Kansas City compared to what we'd seen in San Diego. So you see a very similar diagnosis rate at the time that this data was captured. For those children that were diagnosed, a significant amount of them had changes in care, 78% for San Diego, 52% for Kansas City. The changes in those care could be anything from palliative care guidance to medication change to life-saving treatments, and also avoiding potential surgeries as well. So again, you can see the clinical utility and the downstream impact of this testing really providing a strong case for rapid whole genome sequencing. So what is needed to really make this happen? Obviously, upstream, you need to be able to perform sequencing very rapidly for whole genome sequencing. You also need an informatics pipeline that's able to process the sequencing data and get it into a VCF format that my team, that we can look at in terms of filtering out variants and taking the VCF and taking it all the way to the clinical report. So within our workflow, we have the Illumina sequencers that can perform the sequencing within a day and a half. We have our informatics pipeline of taking the sequencing data to VCF using the Edico Dragon pipeline, which allows the alignment and variant calling within an hour per genome. And through the use of the tool of the QIAGEN Insight platform, we're able to take a VCF into a report, and we've been able to do it in a rapid amount of time. Very important for us is to be able to annotate that VCF and get the proper annotations that we need to be able to interpret the genome through rapid filtering and eventually get a concise clinical report to our physicians so they can comprehend that information. And so QIAGEN provides a great platform for us in being able to filter by various mechanisms, being able to take our phenotypic information, what is the patient presenting with, categorize that, use the ACMG criteria for variant classification, and then pull in the relevant variants into a clinical report. And so now I want to go through 3 case examples that we've seen within our hospital that I summarized before, and kind of walk you through that process, the presentations that these kiddos had, and going through how long it took us to make a diagnosis and what were the downstream impacts. So our first case is kind of a non-traditional case in terms of this was not a child in the intensive care unit, but it was a child that desperately needed the testing. So we had a previously healthy 16-year-old female with cardiac arrest. So she actually had to be defibrillated 2 times while she was actually out playing with her friends when she went into cardiac arrest. And after those episodes, she actually remained chronically fatigued for a year when she was found to be anemic with menorrhagia. And so this is just showing that there was some cardiac problem that was occurring. There was a suspicion of CPVT, but they didn't have a definitive diagnosis for this child. And so we had the opportunity to sequence this child and her parents and perform rapid whole genome sequencing. And so based off of the great notes that we had from our physicians and our cardiologists at Rady, we knew that CPVT was one of the phenotypes that this child was presenting with. And so within this platform, you're able to add CPVT as one of the terms. It'll take the variant information and then prioritize the variants according to that side of things. And so as you can see here in this screenshot, you're able to see the direct link between a particular gene, RYR2, and this particular variant, for this particular phenotype, CPVT. And so what we were able to find in this patient is that we had a variant that popped to the top of our list very quickly in the RYR2 gene that had been strongly associated with CPVT as well. And so the algorithms placed it very close to the top of the list. We were then able to take those variants and perform the classifications according to the ACMG criteria. And so off of the first iteration from the software, it classified this variant of uncertain significance because it didn't have the family information prior. And so this variant was actually found de novo, so it was not found in the parents. And based off of that, this variant then was pushed up to likely pathogenic, in that it was a rare variant in a conserved region, being de novo, and also being in a gene that had been implicated in CPVT previously. And so with that, we were able to make a genetic diagnosis of CPVT. We also found 2 cases in the literature with the same variant with people with CPVT. And so here I put a couple quotes from our cardiologist that was taking care of this child in terms of what a genetic diagnosis meant for their future care of this individual. And so he states, the knowledge of her definitive mutation allowed me to feel comfortable adding flecainide to her beta blocker for the best mutation-specific therapy and arrhythmia suppression. Having her on flecainide at the time made me very comfortable to proceed with far less concern of an intra-procedural life-threatening DT. And so we actually got an update, and this child is doing well. At last check, this is just last week, and we were able to provide the diagnosis very rapidly, and we were able to call it out to the cardiologist on call at the hospital. We actually made a diagnosis on this, I believe it was a Friday after Thanksgiving. And so this was a great instance of providing a rapid diagnosis, having downstream effects on therapeutic targets and implications. And another interesting part of this story that speaks to the power of genetics and how genetic testing is not just for a patient, but for their entire family, is that this child also had half-siblings that the parents were concerned about this particular genetic diagnosis presenting in those children. And so we were able to actually do targeted testing for those children to let them know that they didn't have the variant, and so that their risk wasn't increased over what the background risk would be for a child with an RY/R2 related CPVT. Okay, so now for case 2. A very different presentation here, in that we had a 3-day-old female with tonic and myoclonic seizures. And what we saw in this child, so they were transferred to our NICU at Rady shortly after birth. The first-line treatments for stopping the seizures, anti-epileptics, were all ineffective. So we enrolled this child into our protocol to run rapid whole genome sequencing. And so after the sequencing was performed, the informatics was then conducted. We now moved into the variant interpretation and filtering. So again, I want to just kind of show the slide of what we're seeing on my end from the interpretation and reporting side of things as we analyze the case. And one of the points that I really want to drive home with the analysis of genomic data is that you need to be able to have high-quality sequencing data up front, but you also need high-quality phenotypic information to really help make a rapid diagnosis. And so we have a team of people that are really digging into the medical records to provide strong phenotypic information for us to do our analysis. And so as you can see in this slide here, we put in seizures. That was the main indication for this child. And so these are the variants now as you merge that phenotypic-driven prioritization with the genomic data that's coming through. And so, you know, we just had a handful of candidates that came through, including a candidate in the KCNQ2 gene. And as you can see, it's involved in a seizure disorder. And so this seemed like a very strong candidate for us to pursue further. And so we honed in on the KCNQ2 variant. This was a missense variant. Again, we had parents in this scenario, so it was a de novo missense variant again, not found in either parents, and a conserved residue. And even though this variant was unreported, there were multiple variants right around this amino acid change that had been reported pathogenic before. And the phenotypic overlap was very strong in terms of the NICU, and the neurologist had a suspicion of Ohtahara syndrome for this child based off of some of the imaging studies that had been done. And this gene is a very strong candidate and has a very strong overlap with Ohtahara syndrome. And so for this particular case, we actually made a diagnosis in 96 hours. So we're able, from our blood sample in the door, to perform sequencing, informatics, interpretation, and calling the result to the physician in 96 hours. And so the very gratifying thing of this particular case, is that the molecular diagnosis actually indicated a very specific treatment regimen. So with children with KCNQ2, Ohtahara syndrome, or encephalopathy, there's a very specific treatment regimen that is recommended and has been well published in the literature. And so first-line treatments actually will not work for children that have the KCNQ2 pathogenic variants. So after receiving this information, the seizures were controlled and the child was able to be discharged shortly after. So this was really a success story for us. And just a quote from one of our neurologists, that this potentially could be the fastest molecular seizure diagnosis that's ever been made worldwide. We can't prove that, but it was a very gratifying story for our team to be able to provide this diagnosis for these children and for this particular child. And so an interesting side note that I want to make for this particular case is we love to have comparisons of why would our testing be better. I do want to bring up the point that, yes, if you sent out a panel testing for KCNQ2, and if you were suspected of seizure disorders, they would have picked up this diagnosis. And that's exactly what happened in a child that they had at Rady last year. So having a KCNQ2 diagnosis is not a very common thing, but they had a child with the same scenario last year before we were up in sequencing at our institute. So they sent out for standard genetic testing for this child, and they came back with the KCNQ2 diagnosis, but that diagnosis came 6 weeks later. And so the child was seizing in the NICU for 6 weeks and could not be discharged for a large amount of time. And so in addition to the cost that goes into a child staying in the NICU that long, the emotional stress on the family, there's potential implications showing the literature that obviously for a young child that is seizing that much, there is a potential for downstream effects neurologically in terms of the lifetime of this child and what it means neurodevelopmentally. So again, this is an interesting study for us to go back, talk with the neurology team in terms of what did this rapid diagnosis mean compared to other diagnoses you had made from standard clinical genetic testing in the past. And so this was a good case comparison for us. And so the last case that I'm going to go through here is a case of a child with congenital hyperinsulinemia within the first week of life. And so they could not control this child's blood sugar, and the child's condition was deteriorating. And so they weren't exactly sure what the cause could be. So they actually had to transport the child to Children's Hospital of Philadelphia to do a very detailed imaging scan, a very expensive imaging scan, to try and determine if something was wrong with the pancreas and what exactly that could be. At the same time, before the child left, we performed rapid whole genome sequencing in accordance with our protocol. And this is one of those cases where the physician had a pretty strong suspicion of what it could be. They actually talked to us beforehand to see, hey, do you cover the ABCC8 gene well? And so we were able to actually go through the process of checking that gene up front, making sure that it was covered well, but putting it through our normal process. So we tried to perform the sequencing, interpretation, reporting as fast as we could. And this was a case where the physician's suspicion lined up with the genetic diagnosis. And that, as you can see here, we put in the phenotypic-driven prioritization along with the variant filtering from the whole genome data. And we came to a classification of a pathogenic variant in ABCC8 that was paternally inherited, which is actually very important for the genetics downstream. And so the ABCC8 variant, we found a stop gain variant, and there was a lot of literature on this variant. There was over 35 papers that were out there. So even though we felt confident about the diagnosis, we really had to comb through the literature and really try and read what was known about this genetic diagnosis and what it could mean downstream in terms of the impact for the child and what is known in the literature in terms of treatment and prognostic value. So as you can see here with the software tool, we were able to capture a lot of those papers up front, which is great. or a person in my shoes that's really trying to capture as much information as possible. And so we were able to make a genetic diagnosis for the hyperinsulinemia for this particular child. And this is an interesting case, and this really speaks to the power of having the parents available for the testing. So the diagnosis, it actually is very important to know which parent the mutation comes from. And so in this particular case, coming from the father, there then was a suspicion of it being focal hyperinsulinemia, which is actually a much better outcome, potential outcome for this child compared to having a diffuse hyperinsulinemia. So with the molecular diagnosis in hand, prognosis does look better for this child. If it clinically confirms to be focal hyperinsulinemia, they're able to remove the sections of the pancreas that have that are altered, as opposed to removing the whole pancreas. And when that occurs, the child will be diabetic and will be a type 1 diabetic for their whole life, which, again, the child can live, but can be very hard to manage and has downstream implications. And so this is, a little bit to speak to the QIAGEN platform and how it's helped us in being able to provide rapid diagnoses for the children. So we have to ensure all parts of our process are well regulated, as well as making sure that they're done as quickly as possible. Having content within one shot, within one click away is very important for our team. And being able to prioritize variants using a network analytics is very important too. So again, we're trying to provide rapid diagnoses where hours could be vital for the downstream implications for this child. So we're, again, really trying to push the envelope in providing as short of a turnaround time as possible. We, at the same time, need to make sure that we're doing our diligence, reading all the papers, using all the databases that are out there, ensure that we provide accurate classifications for the importance of these diagnoses, in that if we make misdiagnosis for this child, it can have a lot of downstream impacts as well. Using the ACMG guidelines for standard variant classification that came out in 2015, we really try to adhere to that framework. And again, being able to toggle back and forth between different views, different filtering mechanisms is important for us, because these genetic diseases are all rare. We're coming across new phenotypes all the time in these kids, new diagnoses that nothing is known about it. So we really have to do our best to provide the diligence that we can. So what is our big picture here? So right now our focus has been the children at the NICU at Rady Children's Hospital. But as we look at the problem more globally, you can see that there are thousands and thousands of kids that need this testing that aren't able to access it. And you can see that in terms of the number of diagnoses that can be performed in San Diego, in California, in the United States, the numbers are really hard to comprehend. And I know it keeps us up at night thinking that there are a lot of children out there that would really benefit from this testing that aren't able to get it right now. And there are roadblocks to that adoption that we're trying to tackle, we're trying to go after, for that ultimate goal of having this be a test that all children that need it are able to get it, to be able to give them a better life downstream. So the big question, who pays for it? So currently medical insurance does not reimburse this type of testing. So clinical whole genome sequencing, although there are other labs that provide clinical whole genome sequencing, the vast majority of reimbursed tests in the genomic testing world are exomes. And that's because exomes at this point are a cheaper test. There's a lot more data out there in terms of exomes and rare and undiagnosed genetic disease. And so we think genomic sequencing is ultimately the platform that needs to be used, because it'll always be the fastest technology using PCR-free. It'll always allow us to interpret and comprehend the vast majority of the genome that we know about. And so we're really hoping to provide the body of evidence for rapid whole genome sequencing. And so the field lacks the large clinical trial study to show the patient and economic benefits. So what do the insurance companies want to see? They want to see that this testing is helpful for patients, it has economic benefit, and has downstream clinical utility for these patients. And so we're trying to design the proper studies within our system and other potential partners to really try and show the body of evidence that this testing compared to the standard of care right now is superior in all these key metrics that insurance companies are looking for. And so we plan to provide that evidence to change medicine forever. And so, again, we really view clinical rapid whole genome sequencing as a first-tier test for these kids in the intensive care unit. And we've seen it in small studies that have been published and some that have not been published yet, providing a huge benefit in terms of diagnoses and clinical utility. But we need to show bigger numbers. So we want to ask the questions that the field are asking. What's the output look like genomes compared to exomes? How do things look if you sequence the entire family versus just sequencing the proband of interest? And how do you automate some of these processes? How do you make it a scalable test? So we just done, a few cases within our experience here at Rady, but we're looking to scale that up and work with other partners to help us scale up this approach because, again, we need to provide this testing to a lot more children than are getting it right now. And so with that, we have a rapidly growing team at the Rady Children's Institute for Genomic Medicine. I'm one in a team. Again, this photo is even outdated. We've added a lot of other members to our team since this was done. And so we are really, looking forward to working with others and kind of sharing our message and how we're approaching this problem that we view as a serious public health problem. And I thank everybody for their time here, and I'll leave you with this note that the children are waiting, and so hopefully we can provide this testing to more and more kids out there. Thank you very much.
Thank you, Dr. Chowdhury, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that green Q&A button at the lower left of the presentation window, type your question into the box that appears on the screen, and click that send button. We'll answer as many questions as we have time for. So let's get started with the questions. Our first audience member would like to know, what is the average turnaround time of results? Sequencing takes an average of 5 days. The interpretation varies depending on, go ahead, sir.
Thanks for the question. That's a very important question, and that's a common question in many of the new people who are getting into NGS. Sequencing generally takes an average of about 5 days to finish, depending on the sample type, and the interpretation varies depending on the negative and the positive results, and the clinical confirmations as it's needed, and what kind of software is used for interpretation. So the kind of software that we can get, either we get QCI Interpret or QCI that we get, these softwares are designed for easy interpretation and faster workflows, faster timings and better response. So, but still, a lot depends on whether your results are negative or positive.
Wonderful, thank you. Looks like we have time for one more question. Do you report secondary and incidental findings?
Right now, our study does not report a secondary or incidental findings. We just are focused on symptom-driven diagnosis for the children.
Great. Thank you so much.
Hi there. This is Shimul Chowdhury that just joined on the line. I apologize for being late. So if there's any other questions from the audience, I'm happy to take them.
Great. We do have one more question from the audience member. How would rapid whole genome sequencing compare with exome sequencing in terms of the time required and the clinically relevant information to be gained?
So this is a great question that the field is asking and a question that we have as well. In terms of the current landscape, clinical exome sequencing is being offered by a variety of laboratories that are delivering high quality products. From the laboratory technical aspect, we do think that whole genome sequencing can be performed a little bit faster in the laboratory side of things, and that it doesn't require a capture procedure. And we do see the potential for whole genome sequencing having some advantages in terms of being able to detect different types of variation within a single platform, structural variants, as well as SNVs and small insertions and deletions. So, I think one of the big considerations for laboratories is that it's cheaper to run exome sequencing right now, and most of the variation that we detect right now is focused on the exome, and so I think that's why it's being offered clinically and being reimbursed more than genomes right now. But we do see the potential for genomes to be faster and potentially have the highest clinical sensitivity compared to other approaches out there for rare and undiagnosed disease.
Wonderful. Thank you so much. Do you have any closing remarks you'd like to add, Dr. Chowdhury?
Yeah, so thank you again for the platform, and I apologize for coming in a little bit late. Here at the Institute, we're really trying to ask some of the questions of what it would take to implement this testing to become the new standard of care. And so we're actually going to be running some clinical trials to look at exome versus genome, singleton versus trio analysis, and try to look at that systematically, to look at outcomes and look at the economics. So we're eager to work with other children's hospitals or other people that are out there interested in sequencing in infants and in intensive care units. So please, reach out to us, and I think it's a very exciting time with the new technologies for this type of testing and the positive impact it can have for patients worldwide.
Thank you so much to Dr. Chowdhury, and thank you for your colleagues for stepping in for a couple of minutes to answer those two questions. I'd also like to thank QIAGEN and LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through August 2017. You will receive an email from LabRoots letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Enjoy the conference. Thanks for joining us. We hope to see you again soon. Bye-bye.